Good evening, everyone. Thank you so much for joining the NATF Blood Clot Support Group. Tonight, we're absolutely delighted to have Dr. Suresh Vedantam from Washington University School of Medicine with us. He is the PI of the ATTRACT trial, which I know some of you on the call, I recognize the names, are unfortunately suffering from post-thrombotic syndrome. So hopefully Dr. Vedantam will be able to shed some light on that of new research and treatments that they're looking into. So without further ado, Dr. Vedantam.
Well, thanks very much. It's truly a pleasure to join you all tonight. Thanks to Drs. Goldhaber and Piazza, and also to you, Catherine, and Molly for arranging this. So I'm an interventional radiologist, which for those of you who aren't aware is a physician who specializes in performing minimally invasive procedures under imaging guidance. And I have kind of a specialty area in the treatment of clotting and thrombosis. And I've been involved also in organized research to try and find new treatments for patients who are suffering with the post-thrombotic syndrome or who are at risk for developing it. And that's sort of my really reason for being here. And to me, it's just a terrific opportunity to be able to interact with people whose lives are actually affected by this. I have a clinic that I, each week where I see patients, and really the clinic is probably 80% patients that have the post-thrombotic syndrome, usually of a moderate or severe variety. And so I've gained a lot and learned a lot over the years, and I hope to learn a little bit more tonight here. A couple of disclosures here. I'm going to move the slides here if I can make that happen. Let's see. There we go. So I've received grant support from the NIH as well as from a number of companies that supported the ATTRACT trial here. Some of the clot-busting drugs that we talk about and the stents that we talk about are approved for use in the United States, but were not specifically designed for use in the veins, and so they're what we would call off-label, and that's just something to disclose to you now. So, as many of you will know, deep vein thrombosis or a blood clot in the leg, the physician's view of it really, when a patient comes in, is to first and foremost make the diagnosis very quickly, make sure the clot doesn't go to the lungs, because obviously deep vein thrombosis, one of the major complications is that can break out, go to the lungs, cause a pulmonary embolism, as we call it, and that can even be fatal in some patients. Select an optimal anticoagulant drug, sometimes called blood thinning drugs, but for treatment, and that will prevent typically the clot from moving to the lungs once it's started, and will also prevent the clot from extending in most patients. Assess the patient carefully to determine, does the patient need to be in the hospital? And these days, most patients can be treated as outpatients. They don't need to be admitted, but it depends a lot on their medical condition overall, really. Not so much the clotting by itself, but other factors as well. Sometimes the reason for the clotting is a reason to be in the hospital. And then finally, in terms of deciding how long a patient needs to be on blood thinning drugs, typically we're guided by, in what situation did the patient get the DVT in the first place. If it was due to a major provocation such as surgery or an accident or something like that, when that risk factor is gone, then the patient shouldn't be at high risk for having another blood clot. And so typically you can stop the blood thinning drugs relatively soon after a few months. On the other hand, if you don't have a clear understanding of what the risk factors were, then maybe there's either a genetic factor at play or something else, and then those patients typically require longer treatment. Now, again, that's the doctor's view. When we think about our patients, and again, I hear patients tell me their stories, on a weekly basis, and what they see with the blood clot is obviously very different than what the doctor sees. And I am only imagining, as a physician that's talked to patients, some of the things that are on their minds, obviously just fear about, dying from a pulmonary embolism, to have all of a sudden your leg kind of blow up and get large and tender and all that, and you've heard on the news or you've heard people talk about blood clots and how deadly they are, that has to be absolutely terrifying. I think that many patients, of course, are concerned about what that's going to mean for their long-term health. Obviously, patients need to be treated, and the treatment, I think patients are, enthusiastic to receive it. On the other hand, as many of you know, can be very inconvenient depending on what treatment you get. Up front, depending on what anticoagulant drug you get, you may get shocks. They're not really enjoyable to receive. You may have to take a pill, and for many people that's inconvenient. And of course, early on when you first have that experience, getting treatment may feel like a relief, but over time, once you get back home and you're trying to resume your daily life, having to deal with taking medications and all that is not something that people necessarily enjoy. And then finally, the thing that we're going to talk about today is that patients continue to have symptoms in their leg. And that varies a lot from patient to patient. Some people have it pretty mild or may even recover completely. Many other patients don't, and they continue to experience leg aching, swelling, heaviness, fatigue, and in a minority of patients that can even cause quite significant disability and prevent them from working or walking very far without pain or conducting their normal daily activities. So really this is a condition that certainly poses deadly risks that as doctors we have to get in front of. On the other hand, we also need to be thinking about what our patients are actually experiencing with the disease over time. Now, some of the good news recently, of course, that many of you will be aware of is that there are new drugs that one can take, and now there's a number of choices for medications to treat DVT. The new oral anticoagulant drugs are as effective as the older drug warfarin in preventing recurrence of the clotting. They seem to be a little bit safer than warfarin in terms of reducing bleeding. Warfarin is the same thing as Coumadin in terms of reducing bleeding a little bit compared to warfarin. They're more convenient to take on a long-term basis, and that's a big deal. A lot less hassle with worrying about, how much, what types of diet you're eating and making your diet regular on a daily basis. Less interaction with other medications that you may be taking, and less of a need to monitor patients. In other words, with the new drug, you don't need to have your INR tested once every few weeks or every month or whatever. Now, the other side of the coin, though, is that these days, patients get less interaction with their providers during the early days and weeks after they form a blood clot. Years ago, if you had a blood clot, you'd be put on heparin, admitted to the hospital, and you'd be there for a week. And your doctor would come in and check on you on at least a daily basis, and you would have the opportunity to tell your nurse or your physician that you're having more pain, less pain, whatever it is. Whereas nowadays, you get sent home, which I think most people view as a good thing. On the other hand, there's no one there really to tell about your symptoms. And so I think that's one of the potential downsides now. So I think that, DVT causes leg pain and swelling. When you get put on blood thinning drugs, the improvement may take weeks to occur in many patients. Some people it takes longer, and fully 1/3 of patients never return to their baseline level of symptoms and quality of life. And that's very, very important, obviously, and we don't always think about that as physicians. We're so focused on preventing you from dying, for example, from a pulmonary embolism, that we're not always also giving thought to some of these other challenges that are important for patients. You can see here on the left a patient with a large swollen right leg that's very tender to the touch as well. And in the middle you see a picture of a venogram, which is a kind of a dye, you can call it a dye injection into the vein. And the dark part is the dye in the vein, basically, and it's outlining this light part that has, and I'm going to try and use an arrow here if I can. Well, yep, this light part here that has a big blood clot inside of it. And again, that blocks the vein. It causes the leg to swell up as a result, and the leg gets very inflamed and tender because the body reacts against the blood clot. And that process is called, in a very generic way, inflammation. But it's basically because the body is reacting against that clot. Now, over the long run, patients can develop something that's known as the post-thrombotic syndrome. And again, most typically, it causes daily chronic leg pain and swelling. That's by far the most common experience that patients have with post-thrombotic syndrome. But there's a lot of variations. People have varying degrees of pain, location of pain. The relationship to activity and walking can vary from patient to patient. Typically, it's going to be made a little bit better by elevating the leg. The leg can be very tired. And then some patients will develop skin changes that can even progress to skin breakdown, something that's known as venous ulcers. And I've shown you about the most dramatic case of a venous ulcer I could find, I think that one thing that's important to point out is that only a very small minority of patients with the blood clot get this bad with their post-thrombotic syndrome to where they have this large of an ulcer. So I don't think that you need to be necessarily worried that you're going to go in that direction if you're not there already. But it is something that does occur in a few percent of patients. And obviously you can imagine when people have the post-thrombotic syndrome, and it occurs to some degree in maybe about 40% of patients with a blood clot, it does impair their quality of life and their functioning. There's no proven, consistently effective treatments once it's there. And once it's there, it's lifelong, really. It's not a condition that just sort of disappears, really. It does wax and wane quite a bit from day to day in patients, and people will go also for periods of time where they're a little bit worse versus a little bit better. But overall, once it's there, it tends to stay for a long, long time. Ulcers, when they form, they tend to be challenging to treat and get to heal durably. They often will recur. Now, in terms of why this develops, we don't have a complete understanding of that yet. The two factors that seem to be involved that we know of are that, first of all, that inflammation that I talked about, the reaction against blood clots, causes damage to the one-way valves that are inside your veins. When you're standing up, typically you have valves in your veins that will close and prevent the blood pressure from being transmitted down into your leg through the veins. But when your valves don't work properly, then that pressure gets transmitted, and that's what can lead to that heaviness sensation and the swelling and the aching. In addition, when you get put on blood thinners, your body can chip away at the clot and try and get rid of it, but really the blood thinning drugs themselves aren't active clot busters. And so clot removal occurs to a variable degree in different patients, and some of the clot can stay in the vein, and quite often does, and can block the vein and block blood flow there and cause what we call obstruction. And those two factors, reflux and obstruction, they basically elevate the venous pressures much in the same way that a traffic jam down the road causes a backup, really. And that's what ultimately leads to the swelling and the skin changes that occur and with post-thrombotic syndrome. Now, preventing it is something that has kind of eluded us for many years. We know that having more clotting events in the same leg tends to make the syndrome worse, and that people that have it tend to have had more clotting episodes than people that haven't. If you are on Coumadin and you are not in the proper treatment range with your INR for more than half the time, you're more likely to develop the post-thrombotic syndrome, which basically means that, you know, anticoagulation is probably somewhat effective in preventing post-thrombotic syndrome. There's some early suggestions that injections of Lovenox or other low molecular weight heparins as long-term treatment instead of a pill, for example, might be able to reduce the post-thrombotic syndrome, but that's not really clear, and obviously that's a very difficult thing for patients to do, very impractical from the standpoint of both the pain and the bruising, and of course the cost as well. The new anticoagulant drugs, the effect upon the post-thrombotic syndrome has not been studied yet, and so we don't really know if they'll have a positive or negative effect on it compared with the older blood thinning drugs. People have used compression stockings, and compression stockings can be helpful to reduce swelling in the leg, and maybe some of you wear them already, but they don't actually prevent the post-thrombotic syndrome per the best evidence that we have at present. Now, many years ago, this idea came that, okay, well, if the blood clot is causing the inflammation and blocking the vein in the long run and causing the valves to fail, if we remove that clot right up front in a more aggressive way, can we prevent those problems down the road? That's kind of what we call the open vein hypothesis. Does early clot removal improve a patient's long-term health? And over many years, people have tried different methods of doing that. For a while, people were actually putting people through open surgery to open up the groin and then just literally open into the vein and then just pull out the clot surgically. But that was a very invasive way to treat the disease, and it recurred often and wasn't very well tolerated by patients, not an easy thing to do routinely. And then, of course, clot-busting drugs, very powerful drugs, have been used and given through an arm IV, for example. And actually, Dr. Goldhaber, who was the the original president of NATF, was one of the people that really was the leader in studying this way back when in the 1980s and early 90s. But the problem with that was that the risk of bleeding with those drugs was pretty high, and you had to give a very large dose of the drug. Now, over the last 20 years, interventional radiologists have found innovative ways to deliver those clot-busting drugs into the clot. And a procedure called catheter-directed thrombolysis, basically what we do is through a tiny incision, maybe about 2 millimeters, we insert a catheter, which is almost like a long straw. It's very much akin to a garden hose with a lot of side holes in that catheter, and we put that directly into the blood clot in the vein. And then we instill or infuse the clot-busting drug at a much lower dose into the vein. And the benefit of doing it that way is that you get a more targeted treatment that's more effective, and then also you reduce the amount of the drug that you need to give. And because the drug is associated with bleeding, that may make it a safer treatment. And over the years, we've continued to refine those methods. You know, we use ultrasound guidance to make sure we don't hit the wrong blood vessels when we go in. We use lower doses of heparin along with the clot-busting drug. We use less drug, and the drug we use nowadays is called tissue plasminogen activator, TPA, which is the same drug that has been used for heart attacks and strokes. And then we also use stents to prop open the vein, which are little metal mesh tubes you can see in the bluish middle image there. That can also enable us to treat people kind of faster and reduce the overall exposure to the drug, to the TPA. The idea being to reduce bleeding. And over the years, we have steadily improved and made these techniques, you know, closer to a safer method. Now, they're still invasive. They require you to have a catheter procedure and a small incision made and, you know, a catheter put in. The treatments can take anywhere from a couple hours to maybe a day or so. And so it's inconvenient from that perspective, from a patient's perspective. And so because of that, it's important to really know that it works before we subject large numbers of patients to it. So the use of those procedures has been relatively controversial over the years. And the reason is that, as I mentioned, they can cause bleeding. And there really hasn't been a large definitive trial demonstrating that it's worth taking that risk from a patient's perspective. So the ATTRACT study was a large clinical trial that we got funded through the National Institutes of Health in 2008. And this was a large collaborative effort, 56 hospitals around the United States. I led the trial, and Dr. Goldhaber actually was my partner in leading the trial. He actually chaired the steering committee for the study. And we basically had multiple doctors at all these sites that were kind of specialized in blood clot care. And we basically took 692 willing patients who agreed to participate in the study and did what we call randomizing them, so basically almost like flipping a coin. We allocated them to either receive or not receive this catheter-directed thrombolysis procedure. And then all the patients got regular blood-thinning drug therapy and compression stockings. And we followed them for 2 years to look at their results of the treatment. In that trial, we succeeded in enrolling the trial and finally reported the results just this year. And the results were published in the New England Journal of Medicine last week, actually. The study had many precautions to minimize bias. In other words, to really be a fair test of the two different treatment approaches, one without the clot-busting treatment and one with the clot-busting treatment. I won't go into all the details of that here, but some of the ways that was achieved is that other treatments that we provide to blood-thinning drug to patients were provided comparably to patients in both treatment groups. We watched both treatment groups with equal care. Patients and doctors did not know which arm a patient would be assigned to until it happened. And the idea of that is that way that avoids, for example, the doctor saying, okay, well, he's got more symptoms and I'm going to give him this treatment. You really want it to be random because then you know that the treatment groups are, it's like comparing apples to apples. And then finally, the people that assessed the legs in the long run did not know if the patient received the procedure, so they couldn't really be biased one way or the other. We were very lucky to have an incredible amount of support for the study. Lots of experts, as you can see pictured there, in the treatment of the disease. Dr. Goldhaber there, you can see on the right. We also got the endorsement of the Surgeon General's office to conduct this trial. because it's a very important trial in terms of defining a patient's health after a blood clot in the long run. Yeah, results that we reported this year, basically using the procedures, did result in an improvement in leg symptoms in the first 30 days after the patients were entered into the study. So people that got the clot removal procedure experienced less pain and less swelling at 10 and 30 days when they were assessed compared to people that didn't receive the procedure. There was, however, more bleeding in the people that got the procedure as we expected. And that difference between the two arms was about 1.4%. So between 1 and 2 patients out of 100 had additional major bleeding, as we call it. There were no fatal or intracranial, meaning in the brain, bleeds in either arm, so no disastrous bleeds. All of the bleeding complications occurred in people who were over 60 years old, and that matches what we've seen in other kinds of studies of clot-busting treatments, where older patients tend to be more likely to bleed. And we did venograms, which are basically X-ray studies where we inject dye into the vein and we looked at the veins both before and after the procedure was performed and confirmed that indeed the operators did successfully remove the clot in those patients. Now, we looked at the long-term outcomes, and the main purpose of the study really was to determine, does doing these procedures up front prevent the development of the post-thrombotic syndrome in the long run? And what we found is that actually doing the procedure did not prevent the post-thrombotic syndrome from occurring. It occurred in about half of the patients in both treatment arms, whether or not they got the procedure. Recurrent clotting events were the same. Quality of life was also the same in patients in both treatment arms. The only difference we did notice was that patients who got the procedure seemed less likely to develop moderate or severe post-thrombotic syndrome. But that finding needs further exploration, We also found that the procedure was less effective in patients over 65 years of age. So if you're older, you're both more likely to have a complication and less likely to benefit from the procedure. So we would certainly recommend those patients not be treated. As I said, on the other hand, the one positive finding from this study was that while the procedure did not prevent post-thrombotic syndrome from developing, it did reduce the severity of the post-thrombotic syndrome. So patients were rated on a scale. They described their own symptoms and self-rated their own symptoms. And physicians who did not know whether or not they had gotten the procedure assessed their legs at the follow-up visits and looked for the clinical signs, the skin changes, the swelling associated with post-thrombotic syndrome, and scored them on these two scales that we have. And at all time points, patients who had received the procedure had a reduced severity of the disease. And some of the observations we saw are that probably reflect mainly the treatment effect in patients with the largest blood clots in the veins of the groin and pelvis, very up high, what we call iliofemoral DVT. So our new recommendations for treatment are that really clot removal procedures are not something that should be routinely done along with the initial treatment of a patient with blood clots, because it doesn't prevent the post-thrombotic syndrome. It does increase bleeding, and we haven't really shown a compelling long-term benefit in quality of life yet. We think that further study is still worthwhile to do because of the finding of reduced leg pain and swelling and severity of the disease. We think that targeting patients with the largest blood clots in the groin or pelvis is probably the wisest thing to do. They're at higher risk of developing the post-thrombotic syndrome in the first place, and they may have a greater treatment effect as well. We think patients to receive these treatments should be less than 65 years of age and be expected to have a lower bleeding risk and really be very symptomatic. In other words, their legs are hurting pretty badly and are very swollen. And even then, it may be worthwhile to try blood-thinning drugs first for 5 to 7 days and then reassess and see how their symptoms are doing. And if they're not getting better enough, then go ahead and consider doing a procedure after talking it over with the patients. I think we're going to be doing some sort of secondary analyses of the data from this study to really more carefully try and figure out which patients were more likely to benefit in the study and which patients were least likely to have any benefit. We'll be looking at their quality of life. We'll also be comparing the cost of treatment and then looking at some other things as well to look at the mechanisms of how the disease forms in the first place. I'll just spend a few minutes mentioning the fact that once you have the post-thrombotic syndrome, there are a number of options for treatment, and I think it would be fair to say that nothing has been shown in large clinical trials to be compellingly effective. On the other hand, if you try things, you do find that some interventions work well in some patients. And so I think it is worth a patient's time to continue to be seen by a doctor who maybe specializes or sees many patients that have the post-thrombotic syndrome to see if there are interventions that can be helpful to them. So some of the examples are obviously some of the lifestyle advice we give to patients. Avoid having your leg banged up. That seems very obvious. If you build into your day periods where you elevate your legs routinely, that may make it easier for you to get through those periods of time when you really can't get someplace to elevate your legs. People have started to study exercise protocols, kind of supervised exercise, like physical therapy almost. And again, we know that people that have the most severe forms of post-thrombotic syndrome really can't do that. They can barely really walk well without pain, let alone do kind of ride a bike or something like that. But there are people that have milder forms of post-thrombotic syndrome that may benefit from that. Losing weight, if you're overweight, is probably going to be helpful in reducing your severity of symptoms. And then smoking probably contributes to the skin breakdown you can get when people form venous ulcers. There are also medications people can use, herbal supplements that are used in some countries quite commonly. There's one that's on the market in the United States as a medical food. It's called Vascalera, that can be tried, and they can help some patients. Other patients, they don't help. And there's a few other medications like that. A number of compression devices are available. Using elastic compression stockings can be very helpful. Now, one thing with stockings is that they have to be measured to that individual patient and fit properly. And if they're too tight to where it's just impossible to get them on, it's important to tell your doctor so that that can be adjusted. And our philosophy on stockings and compression devices is that you really got to work with the patient over time and find something that works and gets you the best balance of compression and the ability to tolerate them in the first place. And then finally, people that have vein ulcers need to get kind of professional skin care, and there are clinics that specialize in just doing that, and that's very important. Now, I'll mention to you also that opening up veins that have been blocked for many years can be helpful to some patients that have the post-thrombotic syndrome. So this is an example, this is a venogram as we call it, of a patient that had severe post-thrombotic syndrome in both legs with massive swelling. And the reason it occurred in this patient was the patient had a vena cava filter device placed, and it clotted off and resulted in clotting of the veins, and that ultimately led to this problem here. And this vein dye injection shows that there really isn't blood flow filling up nice-looking veins up in the abdomen. This middle picture is the abdomen, the belly. And then on the right and left there are the groin areas where you see these very small shriveled veins and lots of what we call collateral veins or bypass pathways because the vein is not wide open. These are essentially blocked veins. And after we've done a procedure, a minimally invasive procedure, and put stents in those veins, you can see that the veins are now wide open. We're injecting, and you can even see the kind of the stents themselves, kind of a striated appearance to them. But basically now you have blood flow from the groins back up to the heart, and this patient had dramatic symptom improvement. And in the experiences that have been reported in the published literature, maybe about 2/3 of patients treated in this way experienced significant improvement in their leg pain, swelling, and may experience ulcer healing. That's kind of the results that we've seen ourselves as well. I'll mention that there's no good quality studies evaluating this, and so we're doing another study that the NIH is funding called the C-TRACK trial, where we're going to randomize people to receive or not receive these stents to treat the post-thrombotic syndrome that's severe, and we're going to follow them for 2 years and document if their symptoms and quality of life are really improved. And we're very grateful to the North American Thrombosis Forum for supporting our application to the NIH for that study, and we're hoping that they'll be a partner for us as well in kind of promoting the study and helping to conduct it as we go forward. I think it's important to think a little bit about stents from a patient's perspective and really try and understand what they're for and what they're not for. There's lots of reasons patients get worried when they see their legs swollen or painful. And I spend quite a lot of time in my clinic. I probably do more talking people out of doing this than talking them into it, really, because I think it's very important to make sure you're doing these things for the right reasons. Stents are permanent devices. Once I put one into a patient, it's there forever. We've only studied them for several years, so no one can really tell you what happens to these things 20 years down the line, really. When people see that their leg is hurting them on a daily basis, many people are worried they're going to get a new blood clot. Many of them are worried that they're going to develop a blood clot that goes to their lungs and kill them, and I can just imagine that must be an ongoing fear among many patients, especially if they had a pulmonary embolism to begin with. Patients may be concerned that their leg's going to need to be amputated, and really with venous problems, with venous blood clots, that's exceedingly rare, and so really that really shouldn't be a concern for patients. But then again, when you're dealing with a leg problem on a daily basis, it's natural for patients to worry about things like that. And so those are not really reasons to treat someone with stents. Treating you with stents is not going to enable you to get off your blood thinning drugs. If anything, just the opposite, really. The reason to do this is if you really are disabled from your post-thrombotic syndrome, meaning you can't conduct your normal daily activities. You can't work, you can't walk that far without serious pain and massive swelling of your leg, and you really just can't have a normal life. And I think patients like that are the kinds of patients that we can help, and whom the long-term risks and uncertainties of having a stent in are outweighed by the benefits in enabling them to live a normal life, in a near time frame. So some people really do experience dramatic improvement, and it's really probably the most satisfying thing I do in my clinical practice is see these patients back in follow-up, and some of them are just incredibly better. Then again, stents aren't perfect, and maybe a third of patients need retreatment within the first 5 years after they're placed because the stents become narrow or blocked. Currently, the stents that we use are off-label, but there are 4 stents being evaluated by the FDA right now, and so in 2018, a couple of them are going to come up for evaluation, and so we might have FDA-approved venous stents next year, but we don't know yet. It's important to know also that new technologies are under active study. There are kind of bioabsorbable, kind of organic, you could say, tissue scaffolds that are being built and that are being tested, and they don't have metal in them, and so they might be a better fit in the human body for long-term use. They haven't been used yet in these particular veins, but they probably will be at some point after further development process. There are artificial venous valves being developed. There's a number of other technologies as well, and hopefully we'll learn more about the mechanisms of the disease to devise new treatments. So my conclusions would be that for doctors, patients that have a new blood clot, these catheter-based procedures shouldn't be routinely utilized. Rather, you should treat them with blood thinning drugs first, and if patients get worse and they have a large blood clot and they're low risk of bleeding, then you can consider using catheter-directed thrombolysis. I think there are strong indications that these procedures, by opening up the vein, can reduce the severity of the post-thrombotic syndrome, and so I think that it's important for all of us, physicians who manage patients medically, other kinds of health providers, and the proceduralists like ourselves and our patients to partner together to study this and learn more about this and share our expertise to improve patient care. I think we need to do more of these high-quality trials for these costly, riskier therapies to help us define the right targeted use, which patients should get them and which patients really shouldn't. For patients, I think my best advice would be to remember that anticoagulation is really the best established treatment for blood clots. Most people don't need procedures, and we're going to be doing more research to really pick out which patients benefit the most from having these procedures. If you're living with post-thrombotic syndrome symptoms on a daily basis, I'd encourage you to continue to convey that information to your provider. I think that many providers of clot care are more focused on the blood thinning drugs and the INR values and things like that, which is understandable, but I think it's also important for them to think a little bit about what you're dealing with in your daily lives and get you referred to someone that has more expertise or experience with managing the symptoms, and they have new treatments to offer as well. And I think that as you're doing today, hopefully you'll stay up to date with new research and really participate with us in the doing of the research and guiding us on how to do clinical trials in the best way, in ways that are kind of easy for patients to tolerate, so that we can get results that can be used to kind of inform good patient care in the future. So I'll stop there and see if people have any thoughts or comments or questions. I'd be happy to take them.
All right, excellent. Thank you so much, Dr. Vedantam. That was very informative, and I think pretty enlightening for a lot of patients who are struggling with this, because I don't think it's something that a lot of healthcare providers know too much about. So we did get a bunch of questions in over the chat box. I'm gonna try calling on somebody and see if we've got a chatty group tonight. Michelle Andrew, I know that you had a question come in. Are you on the line?
I am on the line.
Okay. Michelle, did you want to ask Dr. Vedantam your question?
Yes, I had a question. I am a 49-year-old woman. I have had a pretty large DVT in my leg, and I now have swelling in that calf every day if I don't wear compression. I do exercise every day, eat pretty healthy, and I guess you probably answered it during your talk. Is this something that I will need to wear for the rest of my life?
I think that, let me ask you this, so you don't have swelling up in the thigh, really?
No.
Okay, yeah, mostly in the calf. Yeah, I think that most likely it'll wax. You said, yeah, it'll wax and wane quite a bit. You'll have periods that are a little bit better than others, but I think that probably, you know, one thing to keep in mind is that the compression stocking is really, it's to help the symptoms. In other words, it's not like wearing it is necessary to prevent a long-term problem, so you shouldn't be afraid if for some reason you weren't able to wear it today or you don't want to wear them for a period of some time because you're doing something. That's not the end of the world. I do think, though, that if you wear them regularly, maybe it's going to help, you know, keep the symptoms to a minimum. But in terms of it being a dogmatic kind of hard requirement that you have to do it, I'd say it's more something that's kind of really to enable you to get about your life, you know, and be able to do the things you want to do with as minimal interference as possible. So, but that said, is it likely to just sort of cure itself? When did you say your blood clot was?
In January.
Right. So it's been about a year,
Yeah.
whatever it was, almost a year. So, yeah, but that's usually by about a year, things stabilize to some degree. And so if you have symptoms on a daily basis, it's likely those are going to continue for a while, you know.
Okay.
Yeah. I mean, the only thing I would say is that, the only thing I would say that sometimes can be a changeable thing. If someone happened to be very overweight, and they lost a lot of weight. I have had some people come back in and tell me, yes, I lost a fair amount of weight and, my symptoms improved a lot, to where I don't need to do this, I don't need to do that, But that's not always the case, but I have seen some people say that, But beyond that, I think you're doing the right thing with the compression, and that's probably what you can do.
Okay, thank you.
Sure.
Okay, so now a couple of questions that we had come in, and this kind of follows along with Michelle's question. I mean, she, was diagnosed fairly recently, just a little under a year ago. Is there anything that you recommend patients do as soon as they're diagnosed with the DVT that maybe will kind of help prevent or lessen the chances of them getting PTS?
Well, there has been a couple small studies that suggest that, it used to be in the past when people had blood clots, they were told to stay in bed and elevate your legs and just kind of stay there and don't move. And part of that was out of concern that the clot could break off and all that. But people have studied this pretty well by now, and really, it's very safe to, once you're on the blood thinning drugs, it's very safe to move around after a blood clot. Now, it doesn't always feel great, obviously, early on, but there have been a couple small studies that looked at kind of early walking compared with bed rest, and suggest that walking early does help the body kind of resolve the clot a bit, and that may help to prevent the long-term problems with post-thrombotic syndrome. I think that it's very important to really be on the anticoagulants, and I think that's number one. Is if you have a period of time where you just have to be very hyper diligent with them, because clot extension is going to just increase the inflammation, and more clotting and inflammation together are more likely to lead to the post-thrombotic syndrome. So I think, also if you take Coumadin, for example, really good control of the INR and just really carefully monitoring it is just, I think, crucially important, really, in giving you the best chance to prevent those problems down the road. So those are probably the things that you could probably do up front.
Okay, great. We had a question come in from Peter Lenane. Peter, if you're still on the line, I'm going to go ahead and unmute you. Peter, can you hear us?
I can. Can you hear me?
We sure can.
Hi there.
Hi, how are you? Thanks
Good,
for doing
thank you.
well this evening.
Sure. My pleasure.
So I have PTS, and I had a clot in July, or my second clot in July of 2016. And what I was wondering, do you think in sort of in your, I've read some of the papers you've written with Aki Sista and others, and
Yeah.
I'm curious, do you think that there's a correlation between superficial vein disease, just traditional varicosity, and DVT, and then when one experiences a DVT with that condition, do you think you're more likely to get PTS as a result of that?
So I think the answer is yes to both, though when it comes to just the relationship between, for example, varicose vein disease or reflux disease with forming DVT, there is a very slight increased risk of DVT in people with varicose veins, but it's slight. It's not something that people have to kind of spend a lot of time worrying about, Now, that said, if you develop a blood clot and you have valvular reflux, that causes varicose veins, are you more likely to develop the post-thrombotic syndrome? I think the answer is yes. And I'll say also that in the patients that we manage that have moderate or severe post-thrombotic syndrome, first, in the very selected patients, first we stent open their iliac vein, the vein in the pelvis, and then we see how they're doing symptomatically after maybe 1 to 3 months. And there's a minority of patients that still have very significant symptoms that limit their activities, and they have major saphenous vein reflux. And then when we go ahead and ablate that saphenous vein, their symptoms improve, And so valvular reflux is part of post-thrombotic syndrome. There are deep veins and there are surface veins, superficial veins. And when it occurs in the superficial veins, you can close down those veins. The deep veins you can't do much about. But when it occurs in superficial veins, you can close them down. And that's one of the strategies that we use in a select number of patients, I guess, with post-traumatic syndrome.
Well, that's exactly what we did. I closed in August my two saphenous veins in my left leg, and initially my pain and swelling was worse, but now it seems I've seen a marked improvement.
Oh, that's great. That's great to hear.
I just would like to share with the group that I'm an avid exerciser, fortunately, and what I have found is there's a machine, and it's not at all gyms, but I think it's a reasonably common machine, which is really a hamstring machine, and you sit on it, and then you raise and stretch the hamstring. Like you would, if you were laying on the floor on your back with a jump rope, except this is a machine where you can set the arc of the leg in various areas, and you can actually, and then at the end of the arm for the leg, there's a bar that you can actually pump with your foot. So not only are you getting the foot pump motion, but it's elevated while you do that. And I find, that just for me, that that's I do that every single day, and I find it's quite helpful. But just because it's elevated and you're pumping.
Sure, it's quite interesting in the sense that there's so many dimensions to this condition. It's not a simple condition in the sense of there's one simple cause of it. There are components of it. There's sort of the vein blockage components and the venous reflux components, but there's also the calf pump muscle function. People's skin differs, in terms of how it responds to all of this. And there are other factors as well. And there have been a couple small studies looking at supervised exercise kind of regimens, and seem to suggest that in people that have kind of mild or moderate post-thrombotic syndrome, that they may be helpful in reducing the severity of it. And it hasn't really been tested in large scale, but I don't doubt that some of the things that you're saying, would be very helpful.
Yeah, yeah.
Great. Thank you, Peter. We have another question that came in over the chat function from Debbie Stewart. Debbie, if you're on the line, I've just unmuted your line. Is Debbie there? Hello? All right, so I'll go ahead, I'll read Debbie's question. She had a DVT that turned into a PE in January. They did a percutaneous thrombectomy, and her clots have dissolved, but she has numbness to the left part of her foot since the procedure was done, as well as on and off calf pain. Does this sound like permanent nerve damage or something caused by the procedure? And is there anything that I can do for it?
Well, the calf pain, that's harder because obviously if you had a blood clot in that leg, you could it just be some mild form of post-thrombotic syndrome, right? Versus something related to the procedure per se. Numbness, a minority of patients have pins and needles or numbness with their post-thrombotic syndrome. It's not impossible, depending on where they got into the venous system, to have some type of issue related to the procedure, but it's unlikely. I mean, for a pulmonary embolism procedure, which is what it sounds like they did, they usually would go in from the groin or the neck. And if that's the case, it's not likely that this would be related to that, Sometimes with other kinds of procedures, when we go in some of the veins lower down in the leg, you can damage the surface, the superficial nerves, that kind of supply the skin, and that can give people patches of numbness. Usually that goes away in 3 to 6 months. But it would be more likely, I think, to be due to post-thrombotic syndrome. But again, of course, this is hard to assess it. This is obviously a brief kind of description of it. We would, of course, want to hear more about it to understand better.
Sure. Okay. A pretty practical question. How do I know if my compression stockings are fit correctly?
Right. Well, it's not totally easy, but I think that compression stockings are the ones that we use to treat venous disease they're meant to be prescription stockings with ankle pressures somewhere between 20 and 40 millimeters of mercury. And typically the stockings are built to have more pressure down at the ankle because that's where you have the highest amount of pressure in the venous system to counterbalance it. Now, in terms of deciding is it too tight, I think that it's more of a practical decision in the sense of if you're able to wear them every day, I think that's going to likely be fine. If you're getting to the point where they're just so uncomfortable to where you just don't wear them on some days, then I think that going back in and just getting remeasured and really working that out probably is a better idea, because nothing's going to work if it's not worn, obviously, right? So I think that that's important. And then I wouldn't be too worried about not having enough pressure. The only thing I would say is that the stockings you get and you just go buy over the counter, they don't have enough pressure. That we know already from other studies. But if you're getting a prescription stocking and your swelling seems to be reasonably managed to where you can go about your day, then it's probably working fine.
Okay, great. You mentioned stenting, and you recommend not stenting for a lot of patients because the stent is in, for the rest of their life. What about retrievable stents? Is there any work being done on that?
So stents are not retrievable. We have filters, as you know, which are a device that have a completely different purpose, that are retrievable, that you put them in and and then within a period of weeks or months, you can go ahead and take them out in the right circumstances, you know. But stents right now for these types of stents are not retrievable. There are obviously, you know, the word stent is used for a very broad range of devices that we put into the body. Some of them are plastic, some are metal. They're all different. And in some parts of the body, the plastic stents can be taken out. You know, but this is not that kind of stent. These are permanent.
Okay.
Yeah.
Okay. To kind of circle back to the exercise, and I know Peter had talked about some of the exercises that he does. Is there anything, any exercises in particular that you would recommend for relief of PTS?
Well, I think that cardiovascular exercise, you know, just kind of good cardiovascular training is important, and it's going to accomplish a number of things in terms of both enhancing vascular flow and strengthening muscles and all that kind of thing. In terms of specific exercises, you know, I don't really have anything that's specific, and I'll tell you too that, you know, there are a very limited number of centers that have a specific program they use and protocol they use, but it's a very limited number of centers, you know, and so we don't really in our center have a real program, you know. In some ways, I wish we did, but that said, I think that regular cardiovascular exercise that works out the legs is going to be helpful.
Okay, great. Is there any experience stenting the popliteal vein with success?
Not with success. With stenting the smaller veins tend to have slower blood flow, and because of that, they tend to clot very easily. The stents just don't tend to stay open there. And then the popliteal vein also is that, you know, it's close to a point of flexion as well, right, behind the knee, and that's not going to help either. But more importantly, we rarely will stent below the groin. Once in a blue moon we will, but we rarely stent below the groin. The stents are usually up in the pelvis vein, the iliac vein, and sometimes down in the groin vein, but below that, pretty infrequent.
Okay. The next question is, let's see. I was told I have a massive DVT. Does the size of the clot, is that any indicator as to whether or not I'm more at risk for PTS?
Yeah, the size of the clot matters a lot in that respect. If your clot is all below the knee, below the popliteal vein as we call it, then, you know, your risk is probably around 20% of getting post-thrombotic syndrome. And if your clot is, for example, all the way up into the pelvis vein, then you're probably more in the range of 60%, you know, and so it ranges, you know, the clot size makes a big difference in terms of whether or not someone will develop the post-thrombotic syndrome down the road. It also affects the severity. If the clot gets to the groin vein or above, then the level of severity of the post-thrombotic syndrome is significantly higher as well when it develops. And so those are definite risk factors.
Okay. Okay, and how rapidly does PTS progress? This is from a 70-year-old man who had a DVT about 20 years ago, and he has still ongoing pain and swelling in his leg. He wears compression stockings for that. You know, is there a chance that it's going to, I mean, should he expect for it to get a lot worse, or is it a pretty slow-moving progression?
Well, when you're that far out, it's usually relatively slow-moving. The thing that would probably make it get worse is another blood clotting episode. That's the thing that's probably most likely to tip it off to getting significantly worse. But if you've had it for 20 years, it's likely to remain stable. But, you know, there's some waxing and waning that occurs. But, you know, most people that develop post-thrombotic syndrome get it within the first 2 years. Maybe about 90 or 95% will get it in the first 2 years after their blood clot. But once you get that far down the road, it tends to be pretty stable.
Okay. Does PTS contribute to additional blood clots?
Well, that's a great question, and I'm not going to say we totally know the answer. You know, it's interesting. People have assumed that the clotting is what causes the PTS. We know that, you know, if you have PTS, you're much more likely to have had multiple clotting episodes. But in what direction it goes, it's not totally clear-cut, and I tend to believe that there is some. I think that it's mostly that if you clot, you're more likely to get PTS and worse PTS. But I think that PTS as a condition, there's some component of chronic intermittent inflammation that is occurring in some people but not others, and these are people that are more prone to get it. And having more inflammation in your leg, it very well may promote more clotting, So it's not something that we have a definitive answer to. It's something that we speculate about a lot when we talk among each other, and I think it's a very good question, really. But I tend to think there probably is a little bit of a relationship there.
Interesting. And do you have any information or ideas? Is there any research going on about using the DOACs in the treatment of PTS or to prevent PTS? And if they're helpful with that?
I don't know about, I think that in just a few of the DOAC longer-term studies where they're looking at extended dose, kind of extended use of lower doses of DOAC, they are building in measures of the post-thrombotic syndrome to kind of evaluate that. But, that tends not to be a big focus when companies are doing studies of new drugs, because the FDA has kind of set out pretty clear guidelines for what's going to get a drug approved and not approved and all that. And they relate mostly to recurrent clotting episodes, which is a little bit of a shame, because then it enables new drugs to come on the market without even checking if they are better or worse or whatever for post-thrombotic syndrome. I think that a couple of the companies are, however, looking at whether the longer-term use can have a benefit in reducing post-thrombotic syndrome.
And it will probably be a while until any conclusions can be made, seeing as those drugs are still fairly new.
That's correct, yeah.
Cool. All right, so second to last question is about C-Tract. And who is eligible for C-Tract? And if patients are interested in learning more, how would they do that?
Sure. So basically, patients need to have, post-thrombotic syndrome, and we define that as, having had a DVT more than a few months ago and having ongoing, symptoms. And it has to be moderate or severe in intensity, so it has to be pretty significantly life-affecting, you could say. And they also have to have blockage in their iliac or common femoral vein, so the vein in the groin or the pelvis, as assessed by some imaging test, whether it's a CAT scan or an ultrasound or whatever. If they have those two things, then they may be eligible to participate in the study. And to get more information, I think that we will have a study website, but we're just kind of getting going here. I think it is registered by now at clinicaltrials.gov, but that will give you only the most skeleton information. I would say you'd be welcome to either email me, or I can connect you with our study team. You can email. I can provide maybe some information to, if I provide information, Catherine, to you or Molly, can that be conveyed?
Absolutely, absolutely. And we'd also be happy to put it up on the NATF website. We have a clinical trials section that we can. Oh,
great.
Yeah.
No, we'll definitely do that. Yeah, we'll definitely provide some information there that everyone can see on the study. And the study should probably start enrolling patients in about, I'd say about 3 to 6 months.
Okay, well, that's very exciting.
Yeah, we're very excited about it too, and we'll see how it goes. It's always exciting when you get into these things, and you never know how they're going to end up, really. So, but that if you did it kind of the right way with a very rigorous process, that at least you're going to get information that's of a high quality and it can be used to improve patient care.
Absolutely. So we're coming right up at 8 o'clock, and so one last question is for the patients who are, kind of suffering with PTS now. Any last words of wisdom or little pearls for them to take with them to kind of help them, continue to manage this?
Yeah, I think that, one of the most frustrating things about the condition is the fact that relatively few providers understand it that well. And I think many patients have had that experience of, saying I've still got problems in my leg, and people say, well, you had your blood clot a year ago, you got your blood thinning drugs, why are you still complaining? And people just don't really understand that, and unfortunately, that's our problem in a sense, right? We have to educate each other a little bit better here. But I think that the key thing I would say is that I would really try and find your way to a physician that has a little bit more specialized expertise in seeing patients with post-thrombotic syndrome. You can consider a vascular internist, an interventional radiologist, a vascular surgeon that maybe just kind of deals with it a little bit more, because I think that there are things that can be tried, and I think that there's nothing out there that is going to work in 90% of people, but most of the things that can be tried are relatively low risk, and so it's worth working with someone over time to see if you can get to a cocktail, you could say, that some combination of compression or medication or herbal supplement or whatever that can help you kind of get through your day easier. So I sympathize greatly. Most of my patients have it, and it's an incredible burden on lives, it's an incredible burden on families, and so I hope we can come up with some better treatments to help with this. But in the meantime, I think don't give up. Just stay connected and be determined about telling people what you're experiencing, because ultimately you'll find your way to someone that hopefully has more insight into it.
Great. Well, I think that's a really kind of uplifting place to end for this evening. And if you want to send me any information on C-Tract, I'd be happy to send it out to the group as well as put it on the website. So just send it our way and we'll take care of it. And thank you so much, Dr. Vaidyantham. This was really informative and really helpful, and we really appreciate you taking the time.
Oh, my pleasure. Thank you so much for the opportunity.
Of course. And our next support group will be on January 30th, again at 7 p.m. Eastern Time. We're having two doctors with us that evening. It will be Drs. Bill Auger from UC San Diego and Dr. Jim Welker down in Anne Arundel, Maryland, and it will be on CTEPH, chronic thromboembolic pulmonary hypertension. So this month we talked about, unfortunately, some of the things that can happen after DVT, and next month we're going to be talking about after PE. So it should be a great presentation, and I hope to see you all then or talk to you then. In the meantime, I hope everyone has a happy and healthy holiday season, and best for the new year. We'll see you in 2018. Thank you.
Thanks very much.
Bye-bye.
Take care.